So the organizers meant this session to be a stock taking of what has come out of this conference. What are we taking away from it? And where are we going as we leave? And it didn't take us long to figure out that that was not something that one person could do. And so we've enrolled 10 additional people to help us talk about what the conference has meant, what it's done, what we're taking away, and where do we see ourselves going as a community moving forward. And each of these folks here come from different parts of what I really think of as the community of those of us that are working to improve newborn survival and health. So I'll just kick it off with a few comments, and then each of our participants, members of our community, will give their own thoughts. So 12 and a half years ago, roughly, when the MDGs were being written, millions of newborn babies were dying in silence. And the world community really left it unmarked. And what this conference has meant to me is that that is no longer true. I look at you and think of the folks that are looking at this on webcast, and think of our colleagues who are doing the work but aren't able to be here. And I realized that we have already come a long way. So we have built a community, and some of us are here. We've done a lot of work in that 12 and a half years to identify what are those 3 major causes of newborn mortality that we and countries and partners have to deal with if we're going to improve newborn survival and health. We've generated the evidence that shows that we have both preventive and treatment interventions for each of those conditions, and that they can be delivered in the settings where that 90% of babies or 90% of newborn deaths is happening. Your programs have shown, for example, that families can and will change their practices in relation to newborn care and newborn care seeking if they understand that it is possible for those changes to help their babies to survive. We've shown together that community health workers actually can provide effective information, counseling, and even care, including in some cases treatment of newborns in their communities, or help get them to the places where that care is available. We heard in this conference both evidence and program experience that shows that. We've shown through the global initiative Helping Babies Breathe that health workers who formerly put babies who did not breathe aside and categorized them as stillbirths now recognize that if they act, they can save most of those babies. And in that change, it has empowered many of them to think differently about how they can act on behalf of newborns. And that kind of transformational change is beginning to happen in the places where we have effective programs. And yesterday was fantastic because it showed how far we've really come. We basically looked at how newborn content has been and is being introduced into policies, national strategies, programs, budgets, systems development. That was a revolutionary step for me. I had not seen in one place so much aggregation of experience of how we are moving newborn into the mainstream, because that's the way, and perhaps the only way, that we're going to achieve newborn health impact at scale, is by making it part of national programs, part of national strategies, put the resources behind it, get the political will, and make it happen at national scale. Those sessions also reminded us of many of the challenges that we still face going forward. For example, we came to understand very clearly that we have not succeeded in making those links to maternal health that are absolutely necessary. We know that with the increasing number of births in facilities, the issue of quality came up over and over again, and we know very little about the quality of care that either mothers or babies are receiving. We also learned that improving quality is not the same as identifying quality as a problem. It has to be a systematic approach that's part of a management structure that really takes on, in a systematic way, the issues of quality. We had some wonderful examples about that. We understood that we need to deal with our human resource issues, that we need more data. We right now do not have good information that lets us know how our programs are performing or whether the outcomes for newborns are improving. We know that we need to harness the incredible potential of the private sector, that we need to engage civil society, and that we need to connect services with families and communities. Those are things we have to do, and we still have quite a ways to go. So as we leave here, we know that we have challenges ahead of us, but this conference has helped define those challenges. But I would dare say that in even the countries where most of us work, it's probably still true that most families and many health workers believe that some newborns just die. That's just the way it is. And our work, we have seen, as with the resuscitation work, can change that expectation. And when we change that expectation, then we will transform the norms, the beliefs, and all of the programs that have to go behind it will be pulled by that change in expectation. So that's a critical part of the work we have to do. So there's a lot to do. But we also have heard, just in that last session, about some of the opportunities that we have. We have the Promise Renewed, the Every Woman, Every Child, the Commission on Commodities. Coming up soon, there's a neonatal nurses conference, which will recognize champion nurses and make the point of that important part of our community. On May 7th, Save the Children will launch its annual State of the World's Mothers Report, but this year it's focused on newborn and specifically on the very first day of life, which is the time when that link between care for mother and care for baby are most defined and tightest. And then there's the Global Newborn Action Plan. So these are tools that we can use to help us do the job that we have to do. But I will argue that while the Global Newborn Action Plan will help us form and set targets for our long-term vision, that we don't have to and should not wait until November to begin working as we leave here. We know in this room, we've heard what we have to do. We know our situations, we know our parts, and in fact, we're the ones that have produced and are producing the evidence and the experience that is the basis for the Global Newborn Action Plan. So implementation starts now for us. We can implement the plan even as it's being written because we know what's in that plan. So what do we have to do? When we go back to our offices, our clinics, our ministries, is to take what we've heard, do our jobs as our part, but also be really part of that movement that the Global Newborn Action Plan is intending to inspire. We are really the core of that movement right now. We are champions, and part of our job is to find additional champions. Part of our job is to be the voice for those newborns when national program strategies are being discussed, when the budget is under discussion, when training is being developed, when the roles of community health workers are being defined, when outreach to communities is happening. Our job is to be that voice for newborns. And so we can start now. We don't start in November. Joy said in one of her slides something very important, that on its present trajectory, Africa will take 150 years to reach the level of newborn survival that exists in the developed world right now. I predict with absolute confidence that that is not true, because that trajectory will change. And that trajectory will change because we will change it. We will do what Gandhi said. We will be the change, as we are being, that we want to see in the world. So those are my reflections, and I invite our colleague Aline from the United Nations, from UNICEF, to share hers.